my name is Dr. HDL, and we're here at the Cardiometabolic Risk Summit in Las Vegas, Nevada. And I'm here with Dr. Carol Watson. Dr. Watson is an internist cardiologist in Los Angeles at UCLA School of Medicine. She's also one of the authors of the ACC-AHA guidelines, which were published in 2013, about changing, the way we think about lipids and LDL, et cetera. She's going to be part of a panel later today that is going to discuss that. But what I wanted to talk to you about now is your talk on cholesterol esterase transfer inhibitors and HDL. We've changed our thinking on HDL. I mean, I grew up with, okay, it's low, it's bad, but if I can get it higher with a drug, it's good. But we've changed. You want to talk about HDL and our thoughts for our changing thoughts?
Right. So low HDL is bad. It's always been bad, and it's still bad today. It's one of the most potent predictors of premature coronary heart disease. So that's bad.
Okay.
The corollary is not always true, though. We used to say, get your HDL as high as possible by whatever means necessary. That's got to be good.
Right.
We've since tried several times to raise it pharmacologically and haven't seen benefit. So in some of the trials with statin therapy plus niacin or statin therapy plus fibrate, we have not seen event reduction. And in some cases, some events with the niacin statin trials, for instance, were worse. Slightly more thrombotic strokes. So we now know that getting it as high as you can by whatever means possible is not right.
How about some of the people that have, we see many women, is it always protective? Because you're talking about dysfunctional HDL. So how do I look at someone that comes in with a HDL of 80 or 90?
Yeah, it's not always protective. So at UCLA, for instance, we had amassed a whole cohort of elderly people out in Palm Springs, all of whom had atherosclerotic events, all of whom had high HDL.
Interesting.
So it's
mostly women?
More women than men, but both genders.
Both.
So not all HDL does.
Any predictors of who's dysfunctional?
Yeah, so there are a number of things that have been correlated with it in some of our studies. Overweight and obesity, the highest. Cigarette smoking, things that we know of as classic risk factors tend to correlate with HDL dysfunction, but not all of them do.
So if I have a patient with high HDL or diabetic, hypertensive, and they smoke, more likely that HDL is not going to be protective. Is that what you're telling me?
More likely than not, not only is that HDL not going to protect them, it's actually possible to turn HDL into a pro-atherogenic molecule if you put it in a very unhealthy environment.
Well, let's talk about the second aspect, the CETP, inhibitors. And I know they're not FDA approved; they're in the pipeline. But we've had a couple that haven't made it. In fact, one that was negative. So you want to talk about those and how we should think of them, what they're going to do for us?
So cholesterol ester transfer protein. That's the protein that facilitates transfer of cholesterol from one lipoprotein to another, typically in exchange for triglyceride. So when VLDL is secreted from the liver and it encounters an HDL molecule, it might suck some of the cholesterol away from the HDL. It might suck some of the cholesterol away from the LDL, leaving a smaller, denser HDL or LDL particle. We know that's bad. Small, dense LDL we think is more pro-atherogenic. Small, dense HDL we think is less anti-atherogenic. So it's not good.
Repeat that, because that was a very key way you said it, less anti.
Yes, it was a double negative. My English teacher said,
that's okay.
Slap me on the wrist, but so small, dense LDL is more pro-atherogenic. Small, dense LDL is less anti-atherogenic.
Excellent point.
Okay, so when pharmaceutical companies decided to develop CETP inhibitors, they thought, well, if we can keep more of the cholesterol in HDL, that creates a bigger functional HDL molecule, and it makes a bigger, fluffier LDL molecule, which would be hopefully less atherogenic, so that should be a good thing. When they developed the first cholesterol ester transfer protein, torcetrapib, there were such high hopes for it.
Right.
It raised HDL 70 to 80%,
Right.
lowered LDL 30%.
Right.
It was going to be great. When they tried it in the Illumina trial in conjunction with atorvastatin,
Right.
it not only didn't protect, there was a statistically significant increased risk of mortality in that study. So it was a very, very, very bad trial result. There was a lot of head shaking and head scratching about what was going on. Turns out they really dug deeper into that molecule, the torcetrapib molecule, and it had a lot of bad effects. It had a pro-aldosterone type effect, so it lowered potassium, raised HDL, raised sodium, raised blood pressure, and that was probably the worst thing. So that was scrapped. The next cholesterol ester transfer protein to go to phase 3 trials was dalcetrapib. Dalcetrapib, they looked carefully at it. It didn't seem to have an aldosterone-like effect. It seemed to be pretty safe. But it was pretty weak. So remember, whereas torcetrapib raised HDL 70%, dalcetrapib did it about 30%. Remember where torcetrapib lowered LDL by about 30%? Dalcetrapib didn't do anything to LDL.
Interesting.
So when they did that study, they saw, after 3 or 4 years, no harm. No benefit, So they figured out how to get rid of the toxicity, it appears, but there was a very weak, non-beneficial molecule left. So what are left in phase 3 studies right now are 2 other cholesterol ester transfer proteins, anacetrapib and evacetrapib. They are both about the same. They both raise HDL very, very strongly, about 130%. They both lower LDL very strongly, about 40%. And in post-hoc analyses or in an adverse events analysis of prior trials, they don't see any of the harmful risks. And they've actually done some Bayesian analyses figuring out that with the results they have thus far, it doesn't look like they're going to ever see a torcetrapib-like effect. So that's a good thing.
So no aldosterone impact. They measured aldosterone with no impact.
And it does not appear to. So what we're left with, we're waiting for their outcome studies. So we're eagerly awaiting the outcome.
When do you think those will be available?
I think probably every clinical trial gives you a projected end date, and it appears to me, at least, that every clinical trial goes beyond that. So I'm hoping to see it all by 2018, hopefully before, but...
Yeah, that's a little bit well. One of the things that intrigues me, if we do get an outcome positive, is it because of the raised HDL or the lowered LDL?
We won't know. I'm sure they'll do a lot of analyses to try to tease that out. But the truth is, we won't know. It's kind of, there's a multiple possible beneficial effects, and we'll have to see what it all shakes out as.
Very interesting. In closing, let me, there's other ways we can raise HDL, smoking cessation, maybe alcohol. Well, we know the drugs we have now, they don't do anything with outcomes. Do I change outcomes? Like if I get somebody to quit smoking, maybe it's not a good example, but say with exercise, with alcohol, that bump, do I get a change in mortality because of the HDL or because of something else?
Such great questions. All the things that work to raise HDL, smoking cessation, weight loss, exercise, healthy diet, all those things also decrease cardiovascular risk outside of HDL. So it's almost going to be impossible to tease that out, but nonetheless, they're still good things to do.
And we would do them anyways. Because our patients with low HDL, as you mentioned, are at high risk.
Exactly.
Yeah, so it's fascinating. Well, Carol, thank you very much for sitting with us.
Thanks for having me.
Enjoyable to see you again.